Okay, so welcome back again to Montreal Heart Institute. I'm Jean-François Tanguay. I have the pleasure to work with Dr. Guillaume Marquis-Gravel.
Hi, everyone.
And Dr. Theophilos Panagiotis that you saw in the previous case a few weeks ago. We have, I think, an entrance case to discuss with you today of stable coronary artery disease, but multivessel in a 60-year-old man. So could I have the first slide, please? And I would like to acknowledge the team here, Christina, Vicky, as well as Aliane, and I think Catherine will be there at some point. So I don't know if I could have the first slide, please.
No, you want to try?
Okay, so again, what we would like to discuss as teaching objective is also the role of imaging versus physiology, or maybe sometime both in some specific cases. Next one. Again, this 60-year-old gentleman was referred from another center for stable angina, de novo stable angina. He had no previous history of coronary artery disease, was treated with for new dyslipidemia and hypertension, and he had no history of diabetes mellitus. He had a positive stress test, quite severe positive stress test at the other center, and was sent to us for coronary angiography. Next slide. Again, we'll show you in a few seconds, but it was multivessel, so quite a surprise to him. Proximal lesion, the Medina 010, a mid lesion that was 50 to 70%, and a distal lesion that was quite severe at 70 to 90%. The circumflex had also proximal lesion that was 70%, OM1 as well. And the RCA had, again, a multi-site lesion. Could we have the angiogram from last week to show, please? So if we can run the LAD, please, the first shot at the left. So I guess now we see live today, but I would like to see, do you see the angiogram? Yes. So you can see the proximal LAD. The mid LAD, we'll see better in this view. Keep this view for 2-3 shots. Proximal LAD, mid LAD, and then a distal LAD.
Okay, 15-25 si on veut.
With bifurcation of diagonal, but they're not. They don't appear to be a disease at this time. So next one. So we see again the lesion on the left system, the circumflex that's quite severe also. And next one, please. So the spider also. So we discuss again the plan, but the right had disease in the proximal part, the mid part. I have to work on that, and distal intermediate. So we'll see. You can see the collateral to the left, suggesting that the lesions on the LAD are quite severe. So we don't need probably physiology for the left. We were planning more imaging to kind of look at the landing zone of the stent and the proximal LAD with the left main. And the goal was today to illustrate the LAD first, multi-site lesion. And there's calcium. We'll show you in the IVUS in a few seconds.
Test.
The next lesion we'll do will be the right, and then use physiology with co-registration to demonstrate which lesion, again, we haven't done it, which lesion are significant that require to have a stent. So that will be the co-registration with the Philips system. Could we go back to the PowerPoint slide, please? Okay, so that's I showed you the angiogram. We are planning to start with the LAD first, probably 3 stents.
And cross.
Probably we will avoid the left main from what we see angiographically, and we'll show you the IVUS. And then the circumflex, and then in a second attempt, do the right after that. Next slide. So again, for this case last week, we first discussed with the patient the potential for bypass because he had quite important disease. He's 60-year-old, but he has no diabetes, and the LV function is normal, ejection fraction of 60%. So the two options are a good option, but we had to understand the risk benefit. So we just did a diagnostic, brought him back to the floor. The surgeon saw him, we discussed, but the patient at 2 times refused to have the surgery performed. He really wanted to have the percutaneous solution, which we said is doable with an increased risk maybe of restenosis and recurrent angioplasty, and always the other option of at some point going to surgery in the future. So he today we asked him again if he wanted to have no surgery, and he refused. So we went to consent him for the angioplasty today. It's a stable patient, so we gave him 600 milligram of Plavix, clopidogrel. And you see the syntax score. Syntax 1 is 28, syntax 2 is 26. You see the data with the 4-year mortality, and again with cabbage. But again, at some point, because the patient refused, I mean, we can give those numbers, but it's really is educated decision. The Euro score was 0.5%, and the STS was 0.2%, so a short term with surgery, and the morbidity mortality 2.16%. Next slide, please. Now, one thing that really, in a way, I think changed our practice is the study from South Korea by Lee, published in New England earlier in March this year, suggesting that IVUS or OCT, any imaging strategy, could be helpful to guide complex PCI, which is this case, versus standard angiography. You can see my colleague now are working because they went with the orbital atherectomy or changing wire, I think. But so you can see the curves where the data suggests that target vessel failure was lower, obviously, when you use imaging, either IVUS or OCT, versus plain old angiography. That means that we don't see always very well the landing zone. We don't see always very well if the stents are fully opposed. So I think that's something that we could consider in complex cases like that. The study by Lee suggests that, and there's no increase in renal failure, significant, no increase. Actually, there's less stent thrombosis. In some way, there's less event. But mainly this was powered for target vessel failure, which was highly positive in favor of imaging. Next slide.
So this was if I may, JF, the Renovate trial was very interesting. It's a last of many trials that suggest that actually intravascular imaging is the way to go now, especially for complex lesions. So 1,500 patients undergoing a complex PCI. They needed to have a complex PCI to be enrolled in this study. Randomized 2-to-1 to either imaging or no imaging. About 25% of imaging was done with OCT, and 75 with IVUS, and again, it confirmed that the results are better. The clinical outcomes are better if we make sure the stent is well opposed, is well expanded, there's no dissection, and so on and so on. So here we have a mid LAD lesion, proximal LAD lesion, and distal LAD lesion. A lot of stent lens going to be used. It's calcified. So we did the IVUS imaging before the procedure that confirmed it's a severe calcifications, 360 degrees arc of calcium here. So
do you see the IVUS image? Because we could show the IVUS as we go. They're preparing for the orbital atherectomy, and I'll let Dr. Marquis-Gravel explain his technique. But what would be nice is to be able to show the IVUS at this time. Could we run the IVUS? And I hope you see the IVUS. Please, could we run the IVUS now? Could we start the IVUS? Okay, thank you. Great. So we'll start it now. Okay. We recorded it, so you should see it at some point. Is this the image we recorded?
Can you play the IVUS movie we played, we recorded earlier?
Yeah.
This one, yeah. So we started mid LAD. As you can see, there's a 360 arc of calcium, severely calcified.
You can see the calcium there. Yeah.
Yeah. And as we do the pullback, calcification remains severe. At some point we come in a normal vessel for just a little bit, and then come back to the calcified. The question we had looking at the angio is where will be the landing zone in the proximal LAD, right? From the angio, it looked like we would need to stand flush before the left main in the proximal LAD. So we wanted to use IVUS to decide whether or not we should go to the left main or not. It's very hard from the IVUS images here to decipher where does the left main starts and where does the LAD ends up. So we're gonna we're gonna do some orbital atherectomy and see how it looks like, and then decide where the landing zone is gonna be.
Yeah,
what do you think, JF, about the landing zone for
I
the
think so.
proximal lady?
Again, I was busy specific, but at the same time, I think from the angiogram and now the IVUS is maybe unclear, but we'll do it after the orbital atherectomy to find out. I thought there was a good landing zone in the ostial proximal LAD without going to the left main. But we'll see with the IVUS. So we're working live now.
Okay. So we're about to start the orbital atherectomy. So we use orbital atherectomy or rotational atherectomy here at the Montreal Heart. We think both strategies are much useful. Here we have a lesion with a very circumferential calcification. So we thought that orbital would be maybe the way to go. Obviously, we don't have randomized trials comparing rotablation versus orbital. So we don't know. But in theory, at least, if we have circumferential calcification, orbital atherectomy makes sure that we ablate most of the arc of calcium. Other considerations for using orbital atherectomy is that it addresses deep calcium. Here, we don't know because we used IVUS. We didn't use OCT, so IVUS is not the best strategy to evaluate for deep calcifications. But unfortunately, we had technical problems preventing us from using OCT here. So we're using IVUS. We know that there is a superficial calcification here, but we don't know about deep calcifications.
Good, thank you. So I agree with you. So we'll start going the orbital atherectomy if you're ready.
Yeah, is everyone ready for orbital? Is it on? So we're going with low speed here. Important to go 1 millimeter by second going forward. I don't know if you can hear it here, but the sound is very high frequency. So we're in something, we're in a lesion. One good thing with orbital atherectomy is that we can ablate forward and backwards. Here we go. Gonna let the artery breathe a little bit. The risk of crown entrapment is much lower than with burn entrapment with rotablation, so that's a good thing here. I think we're going to need to do a lot of passages of the crown because from the onset in the proximal LAD, the sound was very high pitched. So one step at a time.
So you have a solution also that's there downstream, Guillaume, as you do it, yeah?
Yeah.
Exactly. Is it on the Viper solution? Yeah.
It's of course.
It's working perfect.
Okay, second round.
You have to be patient, go slowly, and you can go back and forth. And
yeah. So already it's smoother than for this first round. You still hear the high pitch sound here in the mid LAD. So this is an elective case. The patient received a 60/100 of Plavix as a bolus before the procedure. JF, do you have any considerations for DAPT here in this case?
Well,
for a complex PCI?
That was a point for us for discussion about the duration, about the choice. If it was an NSTEMI, no question, it would be either Ticagrelor or Prasugrel, but it's a stable patient. So we went by the data with clopidogrel at this time. We can always discuss because there's multiple stent, there's bifurcation, it's more complex anatomy. He's low risk bleeding, so it could be an option to give a more powerful antiplatelet. At this time, we are on clopidogrel with heparin and aspirin. For the duration, again, multiple stent, obviously some data suggested we could go longer than 1 year, even 3 years. Again, I think with the bifurcation, the LAD, multiple stent, if he tolerates at 1 year, it's something to consider. It's not necessarily a recommendation because there's always that risk of bleeding. But he's 60 years old. He has no increased risk bleeding at this time, huh?
No, normal hemoglobin, normal platelets, normal creatinine, no bleeding issues, so no cancer either.
You want us to take a picture, or are you okay?
Yeah.
Okay. Just for us to see. Okay, interesting.
I think I would do a couple of rounds again because still it was high pitch when I was doing it. So there's still some more work to do, I think.
We'll do a bit
and
more
we try to minimize the contrast, even if the patient has normal renal function at baseline.
Yeah, he has a normal renal function, normal hemoglobin.
Yeah.
Yeah. For the other, there's no significant disease except the cholesterol, hypertension. All the rest are okay.
So one of the challenges here that we haven't foreseen, we are going radial. We are using a 6 French guiding catheter, XB35. We don't have the support we wish we would have here. So the catheter keeps on going in and out. Going to need to be very careful while doing the orbital atherectomy. Here it's very tight here.
Resistance a bit there.
What?
You have a bit of resistance, or is it, you feel?
I feel some resistance, and still very high pitch sound, suggesting that we are in a tight lesion. Here we go. It jumped. So that's a good sign. That means that we work properly. Here we go. We're gonna let him breathe a little bit.
So do you want us to prepare for IVUS, or you plan to continue a bit?
Yeah, I think we could do an angiogram here and then see if we do another IVUS or not.
Okay.
Avez-vous des douleurs, Monsieur Dubé? Comment ça va? Très bien.
Ouais, nous aussi, ça va bien.
So the patient doesn't have any chest pain, remains comfortable. So maybe another run here.
Yeah.
We like to do a polishing run. Here we go. So I feel pretty confident here that we've done a good job. There's way less resistance than there used to be at the beginning. I'm going a little bit too fast here for the orbital. So remember, orbital atherectomy, if we want to ablate properly, we need to go 1 millimeter per second, not more than that. Otherwise, we're going to miss some calcific spots. Okay. All right. Okay. Sounds good. So we're going to remove the crown. Go. All right. Can you do a small test? Just
you would need to move the camera to your hands, but I'm not sure.
What do you mean?
You want to see?
No, just do a small test. Yeah, what we get. Yeah.
Okay, go.
Here we go. It looks good. There's no perforation. So let's.
We need to go distal, or for now we've used balloon to open a bit at the beginning.
Yeah, we opened with the balloon. We didn't go with the IVUS down there because we had a support issue. Yeah. We really wanted to go with the IVUS there. We pre-dilated the distal lesion with a 2O balloon, but we were not able to deliver the IVUS catheter. So I think it's a distal lesion. What do you think? Do you think we should ablate it as well?
I wonder if we could not just ablate it before putting the stent. Maybe reduce the risk of losing the diagonal. I think you have more experience with the orbital atherectomy, but
we're having some support issue here with the XB35. It's going to be difficult.
Okay, so then we go
bring the crown here, unfortunately. So I think we have other options, right?
Yeah.
So if we need to do atherectomy, we can use cutting balloons and so on.
Yeah.
We still have lithotripsy that we use a lot here.
Absolutely.
So
you're coming back, and then you want us to do the IVUS, eh?
Yeah.
We'll prepare the IVUS, please.
Yeah.
Wait, eagle eye.
So can you show the first 10-40, please? So, JF, I'd like to know your opinion. What do you think about protecting the diagonal or not here?
Well, I think the diagonal for now has no disease. So either we bring another wire just to be safe.
Yeah,
that's one thing. I would like to take a picture to make sure that things have not changed. But after the balloon, not oversized, a little bit undersized balloon tool.
Yeah.
There was no seam dissection. So I would maybe not protect it, just put a stent. And then if there's something we could, I think, rewire it. But if you want to go the safe way, we could also put a second wire in there.
Okay, fair enough. It's not a true bifurcation lesion, right? There's no disease in the diagonal. So, obviously we're going to do provisional technique, but are we putting a wire in? I agree with you. Let's just do a picture and decide then. So we're still removing the orbital atherectomy catheter.
Obviously, if I put a stent, I'll go do the pot technique to open that stent proximal to the diagonal.
Yeah, absolutely.
But again, if the flow is not good, if there's you give nitro, you wait a bit, and sure, I mean, you can wire it. But let's see we'll remove the orbital atherectomy, then bring the IVUS catheter down, and there's recoil for sure in the distal lesion. So that's why I suggested, but we could not go down with the orbital it's far. I mean, it's kind of still quite far, huh?
Yep. Okay, so let's take a picture and then take a decision. Yeah. So no, we're gonna use the IVUS, the Boston Scientific IVUS, the HD IVUS. Yeah, okay. We use the HD IVUS here by Boston Scientific, right? It has a very good spatial resolution. It's very high definition. We like it. We have all got an eagle eye too. We have the rotational IVUS too.
You want us to take a picture now?
Yep. So are we in the artery here? Just make a test just to make sure.
Yeah, we're in.
Sounds good. Maybe a little bit of nitro before.
Nitro.
One of nitro.
Ça va bien, monsieur? Nous, ça avance bien. On a dilaté dans les 3 places sur l'artère en avant du cœur.
Parfait.
Okay, nitro.
Okay, ciné.
Yeah, we're ready. Okay.
Looks good. So, obviously with orbital atherectomy, we crack the calcium, we ablate it and we crack it as well. So, even if we still see some calcification on the angio, some of it is cracked, and it's easier to expand the balloons and the stents afterwards.
It's going to be better. Better to prepare than just put the stent, and after that, you have under expansion of the stent. So I think that's a good idea. Should we do IVUS now before putting a stent in the distal part, or?
Yeah, well, in the distal part, we won't be able to deliver the IVUS catheter. So I think we will need to work with balloons first, and
get 2.5 there. Maybe?
Yeah, we may use it 2.5. So let's have it 2.5, 12, 2.5-12 non compliant.
Ouais, s'il vous plaît.
Non-compliant 2.5-12. Yeah. If it opens well, we're in business, so that's good. If it doesn't, then we can consider lithotripsy, shockwave, or cutting balloon, other types of atherectomies, and so on.
Okay, so we'll wait for the balloon. We'll get ready. The ACT was a bit on the low side. This is a Hemotech, so we target 250 without to be 3A, but at the same time it was 230. So at some point, I prefer to give a bit more heparin or radial.
Yeah,
and it's going to be a long procedure. So
want to avoid radial arterial occlusion.
Exactly.
So we're using a fine cross to remove the Viper wire here, there. And then we're going to go back with our workhorse. We use a cyan blue here, just a habit. We like the cyan blue, but any workhorse could work.
Yeah. Theo, now I understand you're looking at me for your fan cross. Good.
Can you shoot just a little bit more distally, Cosmina? Juste qu'on voit le fil distal un peu aussi. Ouais. Okay, you can remove the Viper wire.
Okay.
Sounds good. Take back the cyan blue, and we're going to use do the exchange with the indiflator.
Yeah. Are you okay?
There you go. Is that the cyan blue?
I think it's the Sion blue.
Okay.
Wait a minute. It's kind of really.
Yeah, it's someone tied a big knot. Cyan blue.
Non, c'est correct. Gonna get it.
All right, problem solved. So
you got okay.
We're gonna use the indiflator too.
Where is the
So we don't need this.
Le bout. Bon, donnez notre Machiavel parce que ça a tout loupé.
Okay, here you go, Theo.
Okay, good. The end deflator, where is the end deflator?
You're putting the cyan blue up to the tip of the fine cross. Edwards 26. I think that's a question for the. Oh, how does the efficiency of orbital atherectomy compare to that of balloon angioplasty? That's a good question. So we need a randomized trial to answer that question, right? And we don't have any so far. The Eclipse trial, I think it's close to be completed or already completed. So we need to have some randomized data.
That's for sure. At the same time, the art of angioplasty, sometimes we do things without the data. But I agree that they may not be the most scientific way of doing things, but that's part of our history to innovate and then to gather data and then to adopt. So I agree. I mean, we could have tried balloon first. We could have tried cutting balloon. We could have tried we chose the orbital because it could also go more in size at some point, go back and forth. I mean, Guillaume, I think we discussed that.
Yeah, we can go back and forth. And the other thing with orbital is that we don't. It's one size fits all, right? We don't have to switch burr.
Exactly.
With rotational atherectomy, we need to switch burrs. Orbital atherectomy just adapts to the size of the vessel, so it's one size fits all. And the other thing is that we don't want to have what we call orbital regret or rota regret. That means that if we try with the balloon and it doesn't work, and then we cause a dissection, then we're stuck, right? Orbital atherectomy and rotational atherectomy are in theory contraindicated if there's a dissection. So if we think that it's very calcified and that with balloon it's not going to work, or we're going to have a suboptimal result, there's no randomized data to tell us the answer. But experience says that we don't want to have rota regret, and this is why we used it on that case. Pull back a little bit, just a little bit more. Another test.
Okay, so that's a precision just with the balloon also.
Yeah, pull it just a little bit more. Okay, here. So we have a 2512 non-compliant balloon here, inflated to 14 atmospheres.
Yeah, that's good.
We can go up to 20. That's the rated burst pressure. Cine here. Just see.
Yeah, I think it's important and non-compliant because it could be resistant lesion and gives us, a similar pressure. Across the balloon. So that's good.
Okay. Can you just show us the last cine we just did? Thanks. Okay, this one. Can you no, the last cine with the balloon here. Yep. So I don't know what you think, but do you think it's fully expanded here?
Not sure it's completely expanded.
Right. Okay. So other options we would have here to address the calcification.
Well, cutting balloon, or I know we said the
shockwave.
Shockwave could be another option.
Yeah, and again,
not bring the IVUS down there. We could try now to see if the IVUS goes down, see what kind of lesion we have.
But we know it's calcified already, it's calcified. So it's gonna change the way we address the lesion. Although we could discuss about this. Okay.
The picture pull back the wire. I don't like when they're too far.
Yeah, good point. Want to avoid
perforation,
perforations and V-text. Hold on. Your ventricular rise here.
Guiding is far. Yeah.
Okay, the pressure is okay now. Okay, all right. Let's do a cine. Okay. Make a decision. Okay, it's not bad. Okay.
Wire is in a small branch, and maybe you want to protect the diagonal, huh?
Yeah. So there's something in the ostium in the diagonal here, right? Yeah. Is it plaque shift? Maybe.
Yeah, I think so.
So that's a good size artery. So I agree. Let's protect it. Wire. Let's have a BMW. We're gonna protect the diagonal here.
Put the wire in the LED.
Yeah. Un BMW, s'il vous plaît, ouais. So again, we don't have a randomized data to tell us should we do shockwave or a cutting balloon.
No.
I like cutting balloon. I like shockwave.
Would be nice.
I like shockwave. It's a good technique.
Down and the profile is not great, so we pre-dilated. We did. So I hope it's going to go down, but we could try it.
Yeah, we could try that. It's a good technology, very easy to use. The shockwave.
2.5.
Let's try 2.5.
Right.
OK, on va prendre un shockwave 2.5 par 12, s'il vous plaît.
You put a little curve just to go in the diagonal, please.
So the shockwave technology comes very handy at some situations, just like here. It's just a balloon that is using the shockwave technology or light or Tripsy technology for basically ultrasound, high frequency ultrasound to break the calcium. So it doesn't make the calcium go away. The calcium still stays there. But
we've been using it selectively in resistant lesion before putting a stent, but we've also used it after stenting or sometime in severe in-stent restenosis.
Right.
So there's a different option with the shockwave technology.
Yeah.
We'll go back down, protect the diagonal. Then we will bring the shockwave and demonstrate that to you. Again, like I say, we have a plan when we begin the case, but we have to adapt to whatever situation we have. And that's what we're doing now. I mean, it's not a complication. It's just that, it's resistant or recoil and the balloon was not fully expanded.
Right.
And if we go with a bigger balloon, well, the risk is having a dissection and occluding the diagonal. So I prefer to be safe. Like I said before, go in the diagonal, protect it.
Yeah.
Then probably use shockwave in that resistant lesion. And then we stent it and we see if we have to do what type of stent strategy.
Yep.
But initially was a provisional one stent in that distal lesion. So again, we're preparing the shockwave balloon. Do we have the shockwave balloon? Okay, that's good.
Here we go. Okay, we're all set.
Excellent.
Good. I'm going to put this square away. Good job, Theo.
Okay, super.
I just put it like this so we'll make sure we don't use the diagonal wire. There you go. So I don't know if you can see it, but basically the shockwave balloon here, it basically looks like a normal balloon with just a little bit
larger profile.
A larger profile, right?
Yeah. I mean, I think
there we go.
In some way it changed a bit our approach to some calcified lesion when it's deep calcium.
Yep. Hey, you're right. You said previously that we use it more and more for after the stent was opposed. If it's not perfectly opposed, it's not ideal. It's off-label, but there's some accumulating evidence saying that if you prepare the lesion, you put a stent in, and the result is not satisfactory, then that could be used.
Right.
Again, it's observational data. Like for most of the atherectomy technologies.
I agree.
OK, vas-y, Théo. Non, Orbital, on va arrêter. Tu l'avances encore un petit peu, Liane?
Liane, ouais.
Hold on, Théo. Just hold on a second.
OK, ça fait-tu mieux? The setup, let me see if I can help.
Yeah. Encore un peu, ouais.
OK, like this.
OK, perfect, Théo. Let's go.
OK, good.
Okay, so as you see there, the profile is not as good. Theo is working hard to daughter the balloon down there.
If it doesn't go, then we could address the proximal lesion and then go back to the distal after. But
yeah, that could be a strategy.
I wanted to try how it would go down, so you could see that sometimes the profile is okay. It's going there,
and the bad support with the XB35 is not helping us here.
Yeah.
Okay, good job, Theo. That's great.
Okay.
There. Okay.
So let me test a bit.
Yeah. Okay.
And before we inflate, just a low pressure inflation.
Okay, you're right.
Went out, but...
Okay, so we're just gonna inflate here, and as we're inflated, you can pull on the balloon to engage properly. Okay.
Yeah.
So we go to 6 atmospheres.
Usually I go 4, 6, whatever, low pressure.
Yeah.
And then sometimes you see when you start a little, the balloon could open even bigger, but you see now it's good.
Okay. Do the first round of shockwave. So
you don't hear much, but you have the shockwave.
Yeah.
I usually do several. Even
yeah. Can do 8 rounds of 10
cycle, whatever.
10 cycles, right? With one balloon. Afterwards, you cannot use it anymore.
Okay, you're off now.
Yeah.
We can do another one. And
yeah, on. So here's going to be a bit boring because we're going to do this procedure. So I'm at 8 atmospheres now. He was going to do the shock wave. We're going to do that, 4 or 5 times?
Yeah, exactly. While we're there, at some point, to make sure we have an influence the most we can on the the vessel, and then after that, I think either we decide to stent or we go with IVUS. But I think for sake of time, also, if we see the result is good, I mean, it would go stent.
Well, and the balloon just 1 millimeter or 2. Okay, on here. I'm at 8. Okay. Let's do a cine here to see if the balloon is well expanded. I think it looks good, right? Good. I think it looks good.
I think for 2.5, it's good.
Yeah. Okay, off.
Yeah.
So we're going to do a 4th round. I want to push on the balloon just a bit.
We have to be patient at some point and repeat the cycles and
good.
Yeah, that's good. It advanced well.
Yeah. Okay, on. I'm going to 6.
Yeah, 6.
Okay.
Atmosphere and then another cycle.
Okay. Good. Okay. So the balloon, we kind of argue, do we use the remaining cycles for the proximal LED, but the balloon is undersized, so I don't think it's going to be much useful.
No, I don't think so.
Okay, so let's remove the balloon.
I think it's important to have at least 1 or 1-to-1 size to make sure that the TRIPSY works, because the proximal LED is like, we'll see by IVUS, but what, 4, 5?
Yeah.
Okay.
Okay, so now can you show us the last 10-40, please? With the contrast, last injection we had. Previous one, yeah, this one. Yeah, okay. So for size-wise, the distal reference diameter, again, we would have liked to have the IVUS here, but I think, what do you think? I think with a 3.0.
Distal, maybe I would start at 2.75 and then post dilate with a pot. That's why we have to have the length of the stent long enough to be able to pot.
Yeah, so we need to be at least 6-8 millimeters approximately to diagonal to pot.
I agree completely, and depending on how short the balloon we have, and then distal, you see if it's guiding a 6 French 2 millimeter. Can do the IVUS, but it looks like 2.5 maybe. Maybe 2.75. I think 2.75.
Okay, 2.75, fair enough. And for the length,
at least
let's say 23, just to make sure.
Yeah, but, it's going to be my suggestion to make sure we cover the distal lesion and then go back to be able to do a pot.
Okay, so let's take 2.75 23 stent. Just want to make a test just to make sure the diagonal is still there.
The wire is still in that branch. Okay, on y va?
2.75 par 23. Ouais, test.
Oui, 200. Test.
Ouais. Okay, perfect.
Diagonal is good. It's just the wire that.
Pull on the wire is a bit distal.
I'm a little bit obsessive with those wires. Now, this one is not the hydrophilic that could kind of just go and we don't even feel it. It's a BMW, that one? Which one is it?
So in the LED, it's a cyan blue.
Okay, so you
cyan blue.
Be careful.
In the diagonal, it's a BMW. Okay. Can you push just the diagonal wire just a bit further? You don't want a radio opaque part being in the right under the stress. Perfect.
The stent.
Okay, so we have the stent here. You go. So clearly here we have a complex PCI according to, there was a lot of criteria for depth duration.
Yes.
I mean, a lot of criteria to define a complex PCI. I like the Justino's.
Yes, paper.
It's a very nice
years
paper.
ago, huh?
A few
But
years
still
ago.
very pertinent in our work.
Yeah. And large, like more than 3 stents here. More than 30, 32 or 38 millimeters of stents. So it qualifies as a complex PCI. So this patient may need
3 years, up to 3 years. Huh?
Well, at least a year, not less than that.
A year, but maybe could have longer.
Yeah, if depth is well tolerated during the first year, then we can have the discussion afterwards.
But that's the mid LAD lesion. Huh?
Yeah,
That to be giving resistance to the
delivering
that science stent that has a great profile. Okay, Theo, great.
Very nice.
Convince me that you're able to bring it down. Okay, so down.
So here again, we want to make sure we're at least 8 millimeters above the diagonal to be able to putt.
Do a really good putt.
Yeah. So pull a bit. Yeah. Intradistal here. Pull. Okay.
Not too much. Okay. Not too much.
Let's make a cine just to make sure we're at the right spot.
Good cine to make sure we're okay.
Okay.
Pretty good.
What do you think?
Yeah? Not pull back too much.
No, I think we're good. I think
you're good, or even advance half a millimeter. You see that position of the eye. I think we're just okay with the landing zone.
So I'm going to 14 here.
14, 16, or
16.
These stable are just, they're measured in air. So, I mean, you don't know exactly that the size that you reach. You can see that the guiding is 2. This is barely 2.5 and it's a 2.75. But with the putt, I think I would use a 2.75 or a 3.0 if you want.
I think a 3.0. Yeah, I think a 3.0. We inflated to 16 atmospheres, which goes up to 3.02 millimeters.
Yeah.
So let's use, on va prendre un non compliant 3.0 le plus court possible.
Ouais, s'il vous plaît.
So the shortest we have a 3.0 non-compliant balloon. Just going to do the putt.
Yeah. And then we'll see with the diagonal if we go across, open the strut.
Yeah, and decide afterwards.
You have to adapt the situation.
Yeah.
I'll go see the patient, how he's doing. Monsieur, ça va bien? Je nomme pas votre nom pour vous, la confidentialité, comme je vous ai dit. Ça va très bien, nous.
Ça avance très bien. Ouais, on vient de mettre le premier stent. Il n'y a pas de douleur. OK. Là, il y en a. Ouais, c'est normal quand on travaille dans vos artères, mais là, vous n'en avez pas? OK. So, no chest pain, patient's comfortable.
Bon. Again, this is an elective case. So at some point, we're going to try to open. There's another wire in that small branch. I think.
Tire sur le wire in the diagonal.
So again, elective case means that we're going to try to do everything today. We could also stage, but again, the patient asked us at some point to get everything. He's a youngish man who's working and hopefully wants to get all this done if we can. We have to work safely, take our time.
Yeah. For the circumflex and maybe an IFR of the RCA as discussed.
Exactly.
We have already given a bit more contrast that I would have liked to give. 179.
That's another thing. His creatinine was normal function, but I mean, to consider the contrast with imaging also.
Yeah. So maybe it's a good thing the OCT was, we had technical problems with OCT, so we avoided giving the OCT contrast.
Yeah, I agree. Parfait. Ouais, vas-y. Heart rhythm very stable, pressure very stable, so good guiding we have to check. Okay.
Good job.
Again, the putt has to be careful, really not crossing that diagonal, not to pinch it more.
Right.
So we'll make sure we use also this clear stent to kind of find out.
Yeah. Watch out for the diagonal wire.
Yeah. Are you negative on this, or you could put neutral sometime? Neutral helps. I feel that, again, it's not a long balloon, but the non-compliant, when you put negative, becomes really very stiff. If you put them neutral, at some point, I felt that sometimes they can make a difference to deliver. I'm not sure in this case, but sometimes I do that. Okay, maybe it's not going.
Let me try.
It's a short one. Yeah, try and we'll leave it neutral. The wire were not crossed, Theo, obviously. That's another thing. I'm very careful when I just do 180 degree, not to, how can I say, loop my wires.
So, here, unfortunately, the diagonal wire like came out a little bit, and it's like not possible to
leave it there, maybe.
Yeah. It's not possible to push it back because it's behind struts, right? We're a bit stuck.
No, leave it there. I think I will leave it there.
At least we're going to have a visual marker if we need to go back there.
Exactly. And if it doesn't go, then we could try to remove that wire, recross, or bring another wire into the. You see, good.
Here we go.
Okay, let me see now.
Okay, test here.
Okay, I can test. Be a bit too far.
Yeah, here. Okay.
Okay, ready?
Yeah. Go.
So again, you're right, Guillaume. The wire gives you a landmark.
Yeah.
I really try to be careful not to go
20
distal, and it's a trio, so we can go up. This should open the stand, open the struts to access the diagonal if we need. And usually I like to do a little mini kissing, not to dissect whatever the diagonal, to keep it simple. But I think it may be useful to bring another wire and go in the diagonal, but we'll see the result.
Okay, so again, this isn't really not ideal, like opening.
You want to open something up there or no?
I don't think so. I think we're okay. It's not ideal open, or like doing the pot on the radio opaque part of the diagonal wire.
No.
This is not what we should do usually, but like here we're kind of stuck. So, okay, let's do a cine.
Yeah, cine, ready. Watch, the wire is still advanced.
Very nice. Okay, the diagonal looks good. The result here is good.
The wire is a bit.
So I'm going to pull on both wires. I'm going to pull on the LED wire. It's a bit far. And then I'm going to pull on the diagonal wire just to remove it.
Keep it as a rail for the other stand we have to deliver also.
Okay, yeah, we can do that.
Okay.
Here.
Yeah, that's it.
Okay, perfect. So let's remove this.
So again, sometimes it's just to say, well, okay, we have the wire there. We remove it from the diagonal, but we keep it as a support. And we can always use some other techniques, but
just a body wire is there, so
body wire is good.
Why not leaving it there?
Old technique.
Yeah.
Before we had the guy liner, Godzilla, that can help us a lot. We use a lot the body wire or some kind of zigzag wire. Now I think
okay.
I think we have to decide the length of the stand for the mid. Could we see the previous picture? Yeah.
This one. Okay.
I think it has to be quite long, man. There's some disease.
Yeah, I think there will be a gap between the stands. I wouldn't go up down there.
Absolutely.
But
at least the mid part up to the. I will not use or unless you want to use a completely longer stand for the ostial proximal, but you need to choose a stand that will grow a lot.
Right. Right, because the
more than 3.5 at some point to be able to go to 4.5 or 5.
Yeah.
Laissez jouer, s'il vous plaît. So we have to, how can I say, focus our eye. Maybe we could put one stand there, like a 3.5 maybe, and then go with a shorter but larger stand approximately.
Yeah.
What do you think?
Yeah.
Have do gaps. That. I mean, I don't think there's anything wrong of gaps if there's no disease.
Yeah. Okay, so why don't we take a 3.5 28?
28 would be my choice. Yeah, 28.
Yeah, let's take this.
3.5 28, s'il vous plaît. And then obviously at the end we have to image to make sure that everything is well opposed and that we covered everything.
So in the Renovate trial, the criteria for good acquisitions were you need to have an MSA of at least 80% of the reference vessel. The MSA also needs to be more than 5.5 millimeters square. Okay. And obviously you need to check out if there's no edge dissection, no malposition and so on.
Yeah, it was rigorous. It reminds me of the music trial where it was
Right.
90% of the area. But it was
Yeah.
really very good result. It was bare metal stent study.
Yeah.
And they had very low thrombosis rate, very low restenosis rate. In a way, it was a landmark trial.
Yeah.
Michel Bertrand was the PI initially of that study, the music, I think. I'm not.
And a little bit
Been
later,
so long
there was the ultimate trial too
Yeah.
that I've been using as a
recent.
with MLA of 90% as a
So I think
target.
We'll put the stent, but I think we have to post dilate. I'm pretty sure after, or we do the IVUS and we check.
Yeah, let's see.
There's calcium. Again, the thing I would do is at some point take different views to make sure it's well expanded and the balloon and the stent. But now that we have IVUS, we can benefit from that.
Yep.
Make sure it's symmetric, it's well opposed, well deployed, and there's no dissection, like you said. Okay. Now we have to be careful after to remove the wire. I mean,
yeah, we're gonna remove the buddy wire before inflating for sure.
Okay, the guiding is
so despite orbital atherectomy here, this seems like there's still some calcium hindering proper advancement of the stents.
Yeah, so that's why your question about lithotripsy was a good one. I mean, it was a small balloon, but we may have to use a shockwave or the larger balloon.
Right.
But let's see because you really worked hard with the atherectomy, the orbital atherectomy. So
right.
Calcium.
Okay, so I think here we should consider using the Guidezilla or the guideliner. Yeah, let me try just a bit, but
try it a bit, and then could we bring a Guidezilla a little bit closer to us, please? And hopefully the buddy wire helps you, but if not, you can pull on it a little bit to try to see if it helps also.
Right. Yeah, we'll definitely need a Guidezilla here.
Okay, so we'll remove that.
Okay.
I think we have to remove the other wire because in 6 French, the Guidezilla, the second wire will be too much, I think. Guidezilla, yeah, perfect. There's some extension of guiding that also are smaller, 5 French, 5.5 French. But at the same time, we want to deliver the stent within the Guidezilla. So, and we'll try with.
Want to have a look just to make sure the stent is not broken?
Sure, I'll look at that. So again, when we remove the stent, you have to be careful that. Voilà, j'ai pas de lumière.
Okay.
And that's good.
Looks good. Okay.
The stent is very, very good. Okay.
And again, if it doesn't work with the Guidezilla, we consider using the
shockwave.
Shockwave again. Your bigger balloon.
You go with this?
Yeah.
Okay, Guidezilla.
Thank you.
Do you want to add the stent now or a balloon, Guillaume?
I would use the stent and advance the Guidezilla over the stent to make sure we don't do some harm to the intimal layers to avoid the razor effect if we use the Guidezilla without the stent in.
Exactly.
Guide it.
Okay, so like I say, I keep the Guidezilla up, the stent in the middle and the wire in the bottom. That avoids twisting and having difficulty to enter with the. I mean, these are simple things, but at the same time, important to keep things simple as possible.
Yeah.
So
every detail counts.
Yeah. So Guidezilla up, middle the balloon and the stent, and bottom the wire. And you try to always maintain that relationship so they don't twist. Okay, good.
Absolutely. Okay.
So the stent will be heading in front of the Guidezilla. Excellent. You see, to avoid any complication, like Guillaume said.